Um, Good morning, ladies and gentlemen. At the outset, I'm absolutely thrilled, honored, and privileged to be sharing the 6th boot camp with all of you. And we have lit about 5 lamps there, and next year is going to be a 6th glorious fire or kindling, which spreads the aura of nutrition and safe practices. I'm sure it will do. And I would like to thank the star of the event, which is Dr. Sanjit Seshidharan, and equally backed by his amazing and wonderful team, and also by the IT team of Hans. And I see this is my 3rd boot camp, if I remember correctly. And I see, as always, the hall is very full. And so let me, without further ado, I'd like to start talking about what I was given by Dr. Sanjit, and which is what is lacking in the field of nutrition, right? Well, you don't need me to talk about it, isn't it? What is lacking in this particular field. We all know when we were students in school, all of you all remember those cartoons there that belong to? Cinderella, right? We all know the story. Cinderella, she had a stepmom who made her do a lot of horrible, dirty household work, and while she cajoled and indulged her own daughters. And when Cinderella got an invitation, as you can see in the second particular cartoon, her stepmother said, "Nothing doing, you're staying at home and doing your household work," as such. So stepmotherly treatment, and that is what throughout the world, the whole world, not just in India, in Europe. In fact, the word I've used, Cinderella topic, is by the Americans actually. Nutrition is such a Cinderella topic, they keep saying that everywhere. And not to mention even in India. It is such a Cinderella topic. I say this because recently I had been to one of the biggest corporate hospitals in city of Hyderabad. I went there because I knew the patient's relatives, so they took me around just to, probably to show that they know me. So I went there, and the patient was in the ICU, and I asked the intensivist at that point of time, "So what are we doing about the nutrition?" The answer I got was, "Oh, let him get all right, let him get stabilized, and then we'll think of the nutrition." I mean that is the attitude of, this was in 2020, just as we were beginning to get our pandemic. The throes of pandemic, and I was amazed, and I was not shocked, but I was amazed despite being in the present age. That is the attitude, and that attitude still continues. And it is thanks to such boot camps where we are trying to familiarize and sensitize the others to the field, art and science of nutrition. So what is lacking is familiarity and awareness of anything and everything which is related to nutrition, right? All of us know a bit of physiology, but as clinical dietitians, as clinical nutritionists, as clinical professionals indulging in providing nutrition care support, we all should know slightly more than the ordinary physiology. We know that when we eat food gets digested and it gets converted to water, carbon dioxide, and energy. I mean, that is the basic physiology. But we as professionals should know exactly how much of water is produced, how many calories per given, let's say, a macronutrient, how many micronutrients are required. At the same time, where does this physiology start from? Where does the digestion occur from? We all know that the moment the person starts thinking of food, the process of digestion starts. The moment he or she puts the food in his mouth, that is in all of us sitting in this hall, right? We secrete the salivary amylase, and we start digesting. Now, we should be cognizant and mindful that these things will not happen in the patient. We should know what is normal physiology. To know what is abnormal, you should know what is normal. In other words, to know what is bad, we need to know what is good, right? So, and then gradually there is peristalsis, and then the food goes into the stomach where it is pulverized to small pieces. So much so that less than 1 millimeter in size is not allowed to go through the pylorus. Whilst it is being pulverized there, it gets mixed or sterilized by hydrochloric acid, which is so very essential for absorption of various nutrients, including iron, including calcium, including magnesium, including calcium. They all go down in the first few centimeters of the small intestine, which is jejunum, they are absorbed there. So in other words, they need an acidic melia. And the reason why it's called jejunum means empty. Most of it is absorbed there in the jejunum. So I don't want to give a huge erratic lecture on the entire gastrointestinal tract physiology, but suffice to say that we need to know about the physiology. Right? It's also very important. I'll keep alluding to this physiology on and off as we go down. And as we go down the further, we should know what exactly is happening. As professionals, we need to know what exactly is happening in your patient, and that's what is lacking. We actually try to extrapolate the normal digestion to our patients. So if we actually try and understand that we have a patient who is altered, more than 50%, some centers even have said 70% of our patients are malnourished at admission. Let's put it at 50%. And quite a significant number of them are quite severely malnourished. Now, what does malnutrition tell us? It tells us the patient is not only weak to cough out and expectorate and turn around to avoid pressure ulcers, but it also tells us that he or she is not making adequate enzymes. All his amino acids, because remember, every enzyme in the body is made up of amino acids. All the amino acids are being shunted to something else, to fight the infection, to fight his various insults, to fight the cause for why he was admitted to the hospital. So if you give the patient, let's say, a very nice, healthy food, right, from the hospital kitchen, he will not have the wherewithal, the enzymes to actually digest. Severe malnutrition, that's one of the reasons why we have failure. Despite getting very high quality food from our hospital dietitians, still the patient will not improve. Of course, the other reason for not improving is the primary insult is not being addressed. Right? This is the secondary insult. So we need to, that's why I put in a picture of the gastrointestinal tract there. And then very often we surgeons, we actually, for various reasons, I will not go into that, we actually do a temporary stoma or we remove the intestines and take it out. Right? We need to be cognizant of how much of gastrointestinal tract secretion, succus entericus as it's called, is excreted into the gastrointestinal tract. That's about 6 liters per day. Right? Most of my surgical colleagues, peers, seniors, juniors, they do not feed the patient soon after anastomosis. They have no idea that succus entericus is flowing across the anastomosis without actually causing significant leak. And the only way to increase the healing of that particular anastomosis is increasing blood supply. And how do we increase the blood supply? By starting the patient on minimal enteral feeds, or also called trophic feeds, 15-20 ml. Right? At the same time, the stoma. Let's say somebody has got a terminal ileostomy. Now, what is lacking in some of my colleagues at least is that the amount of fluid that transgresses across the ileocecal junction is on an average is 1500 ml, 1.5 liters. Most of the water is reabsorbed back, and how much goes into the stools? About 150 ml. In other words, from 1.5 liters, 1500 ml to 150 ml is excreted. Of course, even sodium also is excreted, and some amount of potassium sodium is absorbed and some amount of potassium is excreted. More importantly, in the terminal ileum, we have the bile salts, the vitamin B12, they are absorbed, right? So we need to be cognizant if we are bypassing these. Immediately, the moment we see the patient, all these things will be, and that's what is generally lacking even amongst some of the intensivists I interact with and some of the surgeons I interact with. I'm not talking about the surgeons from Raheja's hospital who are students of Dr. Sanjit. I'm sure all of you all are absolute experts in these. At the same time, we need to know a significant aspects of the pathology, the nutritional pathology, right? And what exactly happens to these patients. I'll give a simple example. We have just come out of the throes of very significant COVID-19 disease, the various variants, right? The common denominator of all the patients who were admitted to the hospital, irrespective of what kind of variant it was a cytokine storm syndrome, right? Now, if a patient is already obese and the patient has a cytokine storm syndrome, right, he will have major issues, right? If you have a patient who is already undernourished and has a cytokine storm syndrome, you will have a different kind of issues. You have a patient with cytokine storm syndrome plus GI manifestations of the COVID, the SARS-CoV-2, then we have another manifestations. So we need to be cognizant of what exactly is happening to these, right? And the best way to actually look at that is get an overview. And nowadays we live in 2022, the field of IT, or we are in the digital world. There are many websites, including on YouTube, which actually they simplify so much that it's very easy to actually understand. And also at the same time, all patients are not the same in the ICU, right? We have different kinds. That is one of the biggest limitations of why we can't get an absolute single clinical study from an ICU, because there are different patients, different patients. Even in, let's say, a CT ICU, right? There'll be a different patient. Somebody may be having hypertriglyceridemia, somebody may be having diabetes, somebody may be having hypertension, someone may not be having any of these, just obesity. Somebody may be just normal, but because of his genetic bad luck, he's prothrombogenic, or he's got increased homocysteine and he's got blocks, and that's why he had to undergo a surgery, right? So we need to be aware of all these things. Every patient is not the same. What is same of all the patients is they are at a threat of developing malnutrition. What is common for all of these is they may already be malnourished. What is common to all of these patients is, yes, they do need nutritional intervention. Now, we need to look at the systems and how we actually give this nutritional intervention. Every metabolism results, I've already told you at the beginning, it results in water, carbon dioxide, and calories. Calories is heat, so heat is generated. So if we measure the heat directly by putting a person in a airtight shell, it's called as a calorimetry, right? We can't do that nowadays, isn't it? So when we actually look at I'll just go back a bit, right? Now we are about 65% water. Our human beings, we are about 65% water. Water comes in drinks, water comes in food. There are only two sources. And then water leaves by urine most of the time. It leaves in feces. I've just told you 150 ml. It leaves by sweat, especially in Mumbai in summer. Also in water vapor, what we exhale, right? Now, water, as we all know, is H2O, right? So there is a constant flux of this hydrogen and oxygen in and out of these. Now, what exactly happens is, whenever we actually metabolize the carbon-based micronutrients, which is all three macronutrients, carbon, fats, lipids, carbohydrates, and proteins, they're all carbon-based, right? The C comes from there, and the oxygen actually comes from the water, right? So that's how CO2 is formed. And then the H of the hydrogen is excreted in the urine. So what we need to be aware is that even though water is excreted in four forms, basically, the H part of it goes only in water form. But the oxygen part of it can also be combined to form with the carbon chain, with the carbon atom, to form carbon dioxide. So it can be exhaled. So water can be exhaled in the form of carbon dioxide. At the same time, water can be excreted in the form of water through the standard routes. So once we understand this, that there are many ways to actually, whereas hydrogen has only one way to exit the body, and that is through the water. So once we understand these nuances, it's very easy to actually understand the indirect calorimetry. And at this time, I'd like to pause and congratulate Dr. Sanjit and Dr. Radha for getting their paper accepted on indirect calorimetry by one of the most prestigious journals in the US, right? In the world, actually. So by indirectly measuring how much of oxygen we are consuming and how much of carbon dioxide we are exhaling, right, we are actually measuring the heat, but in an indirect way, and that's what indirect calorimetry means. In the past, person had to be ventilated, but now we have the mobile carts. I'll not go, Sanjit is a bigger expert than me in that. So familiarity and awareness, I've just given you an overview. At the same time, the familiarity with which what happens when you give the patient oral diet, tube diet, what is bypassing? I already told you salivary amylase, right? Sometimes you feed directly into the jejunum, so we may be suppressing the acid in a patient for no reason why, and we may directly be putting the patient, feeding the patient into the duodenum. At times, we put a tube into the jejunum, which means we are bypassing the bile and the pancreatic juices, right? And if you give the patient a very nice, healthy, kitchen-based diet, where is the pancreatic lipase? Where is trypsin? Where is chymotrypsin? Where are all these enzymes? So the patient will not have, and everything is excreted as loose stools. and the dietitian is blamed for that. Oh, you're not doing properly. Instead, if you give in these, at least for the few, till the person is acclimatized, if you give the patient a semi-elemental diet, like a peptide diet, especially in jejunum for a few days, it will be better. At the same time, do not give water, because as I told you, water is I didn't tell you, but water is hypotonic to blood. It enters the blood into the single-layered mucosal cells of the jejunum, and it bursts, and it causes jejunal mucosal necrosis. So we need to be aware of all these things. At the same time, giving the patient partial parenteral nutrition. Sugar can go up, fats can go up, the patient can get sepsis. More complications with central parenteral nutrition, in addition to the insertion aspects as well. Now, what is evolving, and we are at the cusp of it, we are not exactly, we're just scratching the surface, is how the diet actually controls the brain. Right? We know that it controls sleep. We know that it controls how well we feel, how under we feel, how depressed we feel. In other words, serotonin, dopamine, and all these things are directly correlated to what we actually eat, right? And also at the same time, the diet actually helps in the various, all diets are not the same. We are probably around 150, 200 people in this hall. If you have the same kind of lunch which we are going to have, each of us will actually assimilate differently. Each of us will actually handle the food differently, depending on our genes, and more importantly, depending on the mitochondria, how well they are functioning, how well they are not functioning, and more importantly, depending on the kind of gut bugs we are harboring. So all of this is actually presently lacking, at least in the clinical nutritionists which I am exposed to. So that is what is lacking. Now, we all know that inflammation, right? Inflammation is supposed to be a very protective phenomenon, like as shown in this picture. There's a nail, immediately billions and billions of cells come in. So inflammation, there's a production of billions and billions of cells and macromolecules in the form of interleukin-1, 6, tumor necrosis factor alpha, various gamma interferon, and various, all of these are made up of amino acids, right? In other words, any inflammation is energetically a very costly immune response. We need to be aware of that. This is an acute stage. Now, we are in India, the highest diabetics in the world, right? Every fourth diabetic Indian is a diabetic. Every fourth diabetic in the world is an Indian, right? Now, they have a constant underlying inflammation. So guess what has exactly happening in these patients, right? He's actually wasting so much of his amino acids just to fight this chronic inflammation, right? That's why if you take an obese person to his highly sensitive CRP or the conventional CRP, they'll be high, right? So, and also IL-6, it will not be very high, but at least it will be more than the normal limit. So we need to be aware that once you inherit a patient of these with various metabolic illnesses, the patient is actually he's using them in the wrong way. And coming to nutrition, the clinical nutrition, right? This is one of the fields where it's a minefield. Clinical nutrition's research is a minefield, right? In the past, Constantine was one of the emperors after whom Constantinople was named. He actually he was a very scientifically very inclined person. So he took two of his best knights and fed them the same meal. And one night he said, sleep for 6 hours. And the other night he said, jog, run for 6 hours. And after 6 hours, what did he do? He killed them, opened their stomachs, right? And he wanted to see how rest will affect the digestion, how physical activity. Of course, the person who rested actually had a digestion at a more advanced than the poor knight who was actually jogging, right? Now, that is the kind of research we need to know exactly what's happening. But can we do that research? No, we can't do that research. And for that, I'll give you one more example as we go down the slide. So it's very difficult to actually it's one of the most complex issues because, and very, very, very difficult to get a nicely conducted study which is accepted by everybody across the world, right? No. So if you look at the textbook of clinical trials, there are various trials. Most of it is done in the animals. And not surprisingly, quite a few of the studies which are done in animals are extrapolated to human beings. I fail to understand how can a rat, which has got a very low, despite having a long telomeres, its life is very short compared to human beings, right? We do something to the rat and extrapolate that to human beings. And of course, they say it's an animal study, but still we advise it. In the summary, they put a disclaimer, but say it's better to actually give this patient this. So most of it is based on animal studies. The other one, which is a very low quality one, are the observational studies, right? You give something, a particular diet, and you observe what exactly is happening, right? Without any control. The third one is actually this case control trial, right? And then the cohorts trial. You take a particular group, somebody with diabetes only or somebody with hypertriglyceridemia, then you intervene. Then we have the intervention trial. It can be open label or it can be closed. We know what we are giving, such as some of the trials I'm going to tell you. Sometimes even the researcher is blinded. But the gold standard of all of it is the randomized control trial. Now, talking of trials, I know some of you all may be knowing this gentleman there, Ben Goldacre. Young guy, probably still in his 40s, late 40s. He's a professor of epidemiology in Oxford University. And he made a thought experiment once, and he said, if we take all the babies born in Oxford University Hospital, he said 1,000, and divide them into 500, right? And 500, he said, let me give them only fruits and vegetables. The remaining 500, I'll give them only pork, that is bacon, and fried chicken, for the rest of their lives, not just for a few weeks, for the whole lives. And then follow up these kids to see how many of them are developing various aspects of cardiovascular diseases, including acute coronary syndrome and heart attacks, including cancers, including how fast they are wrinkling, and the various other aspects, right? Can this be done presently? No, right? To do that, we have to jail them, because which kid will actually eat only fruits and vegetables, right, in this present? So we had to jail them. That means he himself, in his wonderful perspective on clinical trials, it's an amazing paper, you should read it actually. He says it's mission impossible to get any clinical trial in the field of nutrition, and that's what is lacking in the field of nutrition, right? So clinical trials are very messy. The conclusion is so messy. It could be good for 1 or 2 patients, not for the entire group of patients. It's very confusing. It's very confusing, and not to mention, full of controversies, right? One of the controversies is actually the biggest studies ever done is the Women Health Initiative. It was started way back in 1991. I think it went on till 2015. Umpteen number of papers have been extrapolated and published from this Women Health. I think it's from the New England area of the USA, by the National Institute of Health of USA. What they have done is, they've taken these elderly patients, right, and some of them said, eat regular diet, and the other half said, eat low-fat diet, right, for your whole life, right? Walter Willett is one of the present professors in the D.H. Chan School of Nutrition of Massachusetts General Hospital of Harvard University. And he actually analyzed them. He said there was so much of non-compliance between them. Nobody just stuck on to low-fat diet. Nobody just stuck on to the standard American diet. There was an intermingling, right? And both had diets. Yet, the results were extrapolated after spending 31 billion, 31 billion with a B, 31 billion US dollars, right? And they said that, oh, low-fat diet is good. They never actually, this hypothesis was never tested elsewhere. This is one of the biggest limitations of a prospective open-label control trial, right? And we come to Dr. Sanjit's specialty, that is critical illness, right? Early parenteral nutrition is not beneficial and, in fact, may kill your patient. A panic trial. Does it mean that enteral nutrition is safe? Let's see. Early enteral nutrition is not beneficial in ICU. Calories trial. So what shall we do? Obviously, nothing works. Nothing works in the ICU. So should we go and tell the patient, hey, PN will not work, EN will not work, nothing will work, it depends on your start, so I think let's cut a line and do some mantra and see that you become well. We don't do that, do we? Right? So hence we resort to the observational studies. Now, we all know that the limitations of observational studies. I'll not go into that, but then we miss the mark and they are very, very less precise. And one of the biggest inaccuracies in the field of nutrition is the food recall, right? 24 hours food recall. Today is Saturday. How many of you all remember what lunch you all had on last Saturday? Hands up. Right? I don't even know what lunch I had yesterday. Right? Now, I say this because there was a huge study on cataract. on patients who developed cataract. And it was on food recall. And patients were asked to recall what they ate in the last 10 years, average. They were shown pictures of fruits, of rice, of various things. Did you commonly eat this? Did you commonly eat that? Right? So how skewed, how wrong are these studies? Right? So the food recall is one of the very imprecise. And somebody has done an analysis which was published, I think, in 2015 in Clinical Proceedings of Mayo. And they said that the number of, in one particular study, this is one of the most inappropriate way to actually do food recall, is the number of calories in women. That is 67% of the women, they think that it is inappropriate. They just wanted to impress saying that, hey, I don't eat that much. But their BMI was not commensurating with what they say they have eaten. Right? So obviously, this food recall is very, very, very imprecise. Right? At the same time, different responses to the same food. I just mentioned, if we eat the same lunch, all of us, we may have different responses. An excellent study, a very elegant study done from Israel, reported from Israel, published in a very prestigious Cell journal. They have taken about 800 people, right? They given the same food for 1 week, the same food for all 800 people. Continuously, they were monitoring the blood sugar. Same food, same activity. They were all jailed for 1 week, right? And what did they find? Every person responded differently, right? For the same amount, let's for the sake of this thing, let's say 2 slices of bread, right, which is simple sugar, white bread, right? Glycemic index is quite high, at least over 75, right? Some of them had 50, some of them had 90 responses. So they had different responses. And based on this, we actually say that these are the Indian standard guidelines, these are the European guidelines, these are the American guidelines. So universal dietary recommendations may have a limited value. Again, this is what is lacking in our field, right? It ultimately depends on our microbes, on the gut microbes, apart from our genetics, right? So coming back to the randomized controlled trials, I'm coming to the end of my lecture, by the way. Coming back to the randomized controlled trials, which is the gold standard, it is full of controversies. It is full of controversies. I'll just take one. I've taken only 2 for the sake of mine. The first one is the panic trial. Some of you all may be knowing it came out in 2011, about 12 years ago. EPANIC stands for Early Parenteral Nutrition in the ICU, completing enteral nutrition, right? And the findings of this were that late PN, if you start parenteral nutrition very late, right, then it's better. If you start the parenteral nutrition very early on, your patient will die. This misinformation is still going on in India. Right, before pandemic, even during pandemic, in all my webinars, there is somebody who will always ask me, hey, you are saying parenteral nutrition is life-saving in patients with GI failure. What about EPANIC trial? Now let's see what happened in EPANIC trial, how wrong this is. No, their numbers were huge. That's why NEJM was accepted. One of the positive things of NEJM is it will accept huge numbers, right? Not less than 500 or so. What they have done is, soon after admission, within 48 hours of admission, they started parenteral nutrition. In addition, they also started 20% dextrose. Now, how many intensivists, doctors, clinical nutritionists will start PN and 20% dextrose simultaneously? None. Correct? At the same time, these patients, majority of them were surgical patients, out of which 58.3% or something like that, over 58% were elective admissions. They were just for babysitting there, for monitoring. They were not really critically ill. Most of the patients received parenteral nutrition for 2 or 3 days or 4 days. No, that means that these were not definitely significantly critically ill. And most of the patients left the hospital, left the ICU within 4 days. The average Apache was less than 5, which means it is not a representative of an average patient in the ICU world over. Despite these limitations, their outcome is early parenteral nutrition in the ICU will kill your patient, right? Now, how wrong are these? The other one is, so Steve McClave, the then president of Aspen, within a few months, he along with Martindale, Bob Martindale, who will be coming to Pensa, they actually analyzed all these and said, these results of EPANIC trial should not be applicable for your patient care in the ICU. But how many of my intensivist colleagues have read this follow-up paper? None. They just stuck, it is just stuck. The limitation is EPANIC means no parenteral nutrition. We already are in a country which is very, very malnourished. We inherit 50% of patients who are malnourished with GI dysfunction, and that is what it is. The other one is redoxus. This is about glutamine, right? The biggest proponents of glutamine, Paul Wischmeyer, who's just recovering from his anastomotic leak. Today is day 3 of his leak, after his 24th surgery. And Darren Hayland, and of course there were others. This is on glutamine, and they say, and to their amazement, they thought more the merrier. They knew that glutamine actually helps in ICU, so they went on and gave more. And what did they find? They found that glutamine increased mortality in ICU patients. They were surprised, they were shocked. Limitation of what is lacking. Why? Again, let's look at the study, what they do. Normally, what is the dose of glutamine? About 0.3 grams per kilogram per body weight. That's about 20, at the most 30 grams per day, or maximum 40. These patients received 60 grams a day, both orally or tube and intravenously. If the patient is not on dialysis with AKI, you should not be giving glutamine. They gave glutamine. If the patient is in hepatic failure, you should not be giving glutamine. They gave glutamine. If the patient has got multiple organ failure, these patients had a multiple organ failure of average of 4 organs or more, right? They gave glutamine. Right? The average Apache 2 was about 14 or 16, I think. I don't remember, but very sick patients. So their studies were wrong, and yet they said glutamine is bad. Now they realized that. Where did they go wrong? So Darren Hayland and Rupinder Dhaliwal from Canada, they analyzed this and they said, yes, please do the serum glutamine levels. If they are low, then you can give it. If the patient has burns, give it oral. You can give oral, enteral, or even intravenous route. If the patient is on parenteral nutrition for any reason and the levels are low, you can give parenteral nutrition through the parenteral route. So, but how many of my colleagues have actually read this follow-up paper? Again, a limitation of what is lacking. So lack of familiarity with the follow-up studies is one of the biggest things which actually happens, which is happening in our country. Now, however, I'm not criticizing all the RTCs, but we take RTCs for, let's say, keto diet, or let's say low-fat diet, whatever. Keto diet is a high-fat diet, and we say, hey, it causes these things, and we extrapolate that to long term, right? So it depends on the guesswork again. So we need to be very, very cognizant and very, very mindful that it is a short-term study, so we have to be very careful. So an ideal clinical nutrition research, we should be aware of limitations, how to analyze that paper, what are the limitations of the study, which is one of the biggest lack in the field of nutrition, which means one size doesn't fit all. So for the various diseases, if same disease, for example, if you take COVID-19, majority of them had mild, few of them had moderate, very minuscule, probably about less than 10% or 5-10% were admitted to the ICU. Right? Same disease, different manifestations. I'm not asking you all to read the whole thing, but you should have some idea of the immune response of to various, because nutrition depends on the intensity of the immune system. Now, this is I'll not go into that. Majority of the patients will not have any respiratory manifestations. Some of them do have manifestations. They just get away with not even NIV, just with some help of oxygenation. About 5, maybe 10% of them will need NIV or prone position or even invasive ventilation. Nutrition is not the same for all of these. It is different. So we need to know, we need to be familiar, we need to be mindful, we need to be very, very knowledgeable in inserting, and that is what is actually presently lacking. Also in cancer patients, all cancers are not the same. It depends on the host, it depends on the genetics, it depends on the type, it depends on the kind of cancer, it depends on the site of cancer. It also depends on the other intervening factors such as medical therapy, such as surgical therapy, and non-medical, non-surgical, that is radiation enteritis, various other things. So we need to be aware of those. The biggest thing is gut microbiome. We need to be aware that microbiome, we live in a planet of microbes, by the way. Microbes are not just an occasional one. Take one E. coli, it divides 72 times in 24 hours, 72 times in 24 hours. Give it adequate food, in 3 days' time, it will cover the entire visible universe. It will not, because there is no food for that. So we take this and we give it we give the good bacteria, the probacteria, right? We give food for the good bacteria. There's the prebiotics, especially the high fiber diet. And what these secrete, like short chain fatty acids, that's what we want, are the postbiotics. And that's what we need to give the patient postbiotics. We can't give directly postbiotics. We are ensuring that the patient the bacteria will develop postbiotics. Why? Because these are the biggest anti-inflammatory, anti-neoplastic, and antioxidant effects in the intestine. And they are very small molecules. Short chain fatty acids are very small molecule, 2 to 4 carbon atoms. They go everywhere, in the lungs, in everywhere, and they settle down and they cause anti-inflammation and their positive effects. So we need to be aware. How can I change the microbiome of this particular patient, right? Effects of fasting, right? There is a species called Akkermansia mucinophilia, right? Fast the patient for a few hours, right? Not continuously, especially patients who are very critically ill, those who are not significantly malnourished. You would increase that. So we need to be aware of the microbiota, which is the microbes. We need to be aware of the genes of these microbiota, which run into millions as opposed to just 20,000 of our own genes. And the intestinal responses and inflammation. You start feeding the patient very early on, soon after admitting to the ICU. You'll dampen the inflammation by converting from TH1 to TH2 procedure. So the role of micronutrients, right? We think of everything, but the biggest barriers that are protecting us in the ICU are the skin, the respiratory tract, and the intestinal epithelium. And we need to be very mindful of what are the various micronutrients, right? All the vitamin A, B complex ones, A, C, D, and zinc. Minerals like iron and zinc as well. Now this is a very good one. So by Mette Berger, she's also coming for PENSA. She says that every patient who's in the ICU should be given intravenous micronutrients for the first 5 to 7 days while starting the patient on early enteral feeds. It's a very good advice, right? And if the patient is malnourished, start the patient on thiamine to avoid refeeding syndrome. So by the time of 4 to 5 to 6 days, you should be able to achieve at least 50% of the patient's caloric requirements, and then you can stop the micronutrients, or also you'll be increasing the intestinal function. So be aware of micronutrients as such. Another thing that is lacking is when we do an anastomosis, for example, the one which is on your right side, the various anastomosis, we are bypassing various things. There's a separate diet for all of these things. Lack of time, I'll not go into that. But at the same time, pharmacology, right? Every patient for some reason or the other is on PPIs. It changes the microbiome, it reduces the absorption of various things. There's a drug-drug interaction, drug-nutrient interaction that is lacking. We need to be aware of that. Some drugs cause intestinal hurry, cause diarrhea. One of the most important and upcoming thing is sarcopenia, muscle loss, right? You just can't give the patient more protein and expect him to put on the muscle. There should be some element of physical activity, either active or passive, ideally active, right? So again, I think there's a new molecule called hydroxymethyl butyrate that is coming very soon to India. That will help that actually acts on the mTOR mechanistic pathway of target of rapamycin. It actually initiates peristalsis. Not peristalsis, protein synthesis, right? So we need to be aware of those things. So we, as clinical professionals, we need to specialize in enteral group as well as penile. That's what the British Dietetic Association does, specialists only in those. Credibility, every Tom, Dick and Harry, every joker on the YouTube, they are not doctors. They think they know everything about it. So we as nutrition should take back the credibility and give credible advice. So coming back to my original one. So Cinderella finally met her fairy mother. And ladies and gentlemen, let me introduce your fairy mother to you. He is on my right side, Dr. Sanjit Shashidharan. He is a fairy godmother who will actually see that you will go to the party, and of course, in a hurry, you will forget your slipper, and the Prince Charming will come, try it on, and then you will happily live ever after, right? So nutrition boot camp like this is our angel godmother, and thank you very much again, right? So I'd like to thank everyone and invite each of you all to actually attend the PENSA 2022, which is happening in Hyderabad. And thank you all very much for giving me this opportunity. Thank you all.